My name is Ronan Rooney. Currently I'm with IBM. I've had 2 or 3 different careers in the last while. I started life, as Jerry said, as a social worker for about 15 years in an integrated agency, much like Nick described yesterday. And I couldn't understand the disconnected or disparate agencies that I came to see over in the US and in many other countries as well. I spent a couple of years working for Apple in Paris, where I got interested in the kind of user interfaces and user experiences and all those kind of good things. And then myself and John Hearn set up Curum, which is a Gaelic word that means care and protection. So Be Curamach is a phrase that means be careful. And we set that up in 1990, and we were acquired by IBM just over 2 years ago. Since joining IBM, I've taken on a new role as we bedded in Curum into the IBM world as the Director of Programs of Care in the IBM Research Organisation. So what I want to talk about today is the area that I'm now responsible for, which is Programs of Care, which is a complementary service delivery model for vulnerable populations. So it's an area that I think, having listened to the discussions yesterday, that is kind of very relevant. So a lot of what I'm talking about, I'll try and differentiate between not so much fact or fiction as in the title, but between stuff that we're doing as research and stuff that's available as software. I'm primarily going to talk about principles rather than software. So feel free to ask the questions, I guess, at the end is probably the protocol. The word Curum, just people often wonder where is it real to be invented? It does mean care. This is a photograph I took in the Mater Hospital, which is a large public hospital in Dublin. So I don't know with the shadows on it whether you can see it, but it says Dín Curum Cree. So Cree is the Irish word for your heart. So Táma Cree Brista is what you'd say when you're a teenager and you'd been dumped. My heart is broken. So Dín Curum Cree is CCU, is the English version at the side. So I'm not sure why we put the initials for English and put the full word for Irish, but it's the coronary care unit in a hospital. So that's where that exists. I want to throw, in the spirit of what the stewards have done in the last couple of days, I'm going to leave a question with you. I don't expect any answers though, so you don't need to write them down. One of the things we sponsor back home is a debate between the universities in Ireland, so they all come together for a national debate. And as the sponsor, we get to decide the topic for the debate. So I'm going to, the debate just happened a few weeks ago, but I thought the topic might be relevant for here. So I'm going to leave the topic with you, and maybe you can just have a think about it. I think it's worth a few minutes thought. And the topic we gave them was the question, is not wanting to die a good enough reason to live? And we got some really, really interesting approaches to answering that question. Some of them were very funny, some of them were not so funny as you get a bit older, but it was certainly entertaining, and some of them took it very seriously, so the combination is always good. But as Jerry said, I want to kind of follow on from where Nick maybe left off yesterday, and Dr. Shah talked about it in the morning. I guess when we look at the mission of everything we're trying to do, we've always tried to find a way to say it very succinctly and describe it in a way that everybody can understand. And the definition we came up for that mission is to provide care and protection for people in their times of need and to help them achieve their social and economic potential, which is really easy to say and incredibly difficult to do. That hasn't changed in 100 years or 1,000 years, and neither has the core set of needs that we're trying to address, which are on the right-hand side. And they haven't changed, but what's changed fundamentally is the way we try and deliver that care. We did a presentation many years ago in Germany to the LSV, which I can't pronounce in German because it's about 4 million letters in the word, but it was the Farmers Union, and we were showing off how Curum could produce checks faster than anybody else and do eligibility and everything else. And the guy said, you've just made the situation worse, because what the farmer wanted was not somebody to give him a check that he had to find out how to cash while he was sick. He wanted somebody to come and milk the cows. And I said, well, the software hasn't quite evolved to that level just yet, but we're working on it. Maybe when the iPhone is invented. There's a lot of things you can do with an iPhone, but I don't think you can milk cows with it just yet. But it was really a kind of a eureka moment in terms of starting to think about what we're really about, because the farmer doesn't want money, he wants help. And if you look at vulnerable populations, it's very much the same. I can guarantee you the last time you went to see an elderly person in hospital, they didn't ask you for a check either. They got a smile on their face when you walked in the door, and that was what they wanted. So I think it's very important that we think about vulnerable people as human beings rather than kind of things that we want to generate cash for. When I think about vulnerable peoples, I guess the definition we use is people whose problems and challenges affect more than themselves. So that's my kind of simple definition of vulnerability. And when their problems affect more than themselves, it becomes a lot more complicated, especially when they have multiple challenges. I think there was 2 examples yesterday. One was when Dr. Clegg talked about his challenge, trying to, as a professional and a doctor, to try and get help and support for his family member. And then when Nick talked about Donald trying to do the similar thing on his own, being a vulnerable person in his own right. And the systems that we have today, most people are familiar with all of them in the room, they have evolved where their policies, the funding, the procurement, the governance, the organizations themselves, and even the thinking is systemically kind of program oriented. And that makes the problem for people who are vulnerable significantly worse. In fact, the systems don't deteriorate for those people, they've disintegrated. They just don't work. They work pretty okay for the rest of the time for most of us. If you have to get a brainiectomy or an appendectomy, it tends to happen reasonably painlessly and effectively. But when you want multiple things, things get a little bit more complicated. So we wanted to come up with a model for how do we look after people who are vulnerable, because as I said, the model that's there today tends to be relatively okay for average normal kind of situations. And we tend to not focus, and we certainly haven't over the last 100 years, on those vulnerable populations for all sorts of reasons. The silos, people have individual goals in organizations that are not compatible necessarily with looking after the challenges faced by people who are multiply challenged. So we're talking here on the screen, I guess, even about people, the elderly. They were talking about the JJ population, the foster care population, the at-risk teen mums, and the elderly people. On the right-hand side. Back home, I took one piece of this slide, which is down in the bottom centre, which is the lady with the spray can. And it's a lady called Mabel who became famous back home because she was arrested one night with her spray can at 2 o'clock in the morning. She was out spraying on a wall outside a big football stadium in Dublin. And she was spraying, "I want to grow old at home." So she wasn't the usual graffiti artist that you'd expect to see at 2 a.m. So instead of arresting her, the police took her and they put her in touch with some community services to help her. But that agency then decided to make a poster out of her doing the spraying. And it was interesting because I thought it was really, really powerful. It was a very simple request. I want to grow old at home, but again, incredibly difficult to do. We make it very difficult to do. And it was also interesting that at the end of the day, the poster only ended up on one poster. It didn't end up as a complete campaign. It was just one poster in one place in one city. It happened to be in Dublin, where I happen to be passing by it every day. But it's important because people like Mabel do reach out. So when Nick was talking about Donald yesterday trying to connect the pieces, they do it in their own way. They arrive in ER. And that's their statement that I want help. They know they probably don't need ER treatment, but that's the place they know. Mabel did it by taking out a spray can. We had a lady back in Dublin about 2 months ago who was found dead in her apartment. But when they went into the apartment and found her, they found about 700 or 800 letters. But they were just envelopes. There was nothing inside, and they were all addressed to her and stamped and receipted because she wanted the postman to call. So she'd nobody else. So she'd no other way of reaching out. So she wrote letters so that the postman would have to knock at the door and deliver the letter because she had sealed up the letterbox. So the postman had to knock and she had to say hello and talk for a few minutes. So people do find their own way to reach out. And I think it's important that we're able to respond to that and maybe improve a little bit on those kind of situations. And I think we can. The other thing that's a driver right now, and I know Daniel talked in his opening kind of comments about like this is a time of change. And it's a time of change not necessarily because everybody has become caring, but because people are looking at the cost side of this equation as well. And whether we like it or not, that's a reality, and we should take it and take the opportunity. If people are worried about the money, well then let's kind of leverage that worry and concern and see if we can't do something useful with it. And people have realised that the vulnerable populations drive a totally disproportionate cost, level of cost. When you look at health and social together, it's probably 80% or more of the cost is driven by this small population. And what we really need is a new model of care for these people so that we can actually work together with them. And I think Dr. Shah talked about those problem lists, the parallel problem lists, and Nick talked about not just health and not just social. So I think that's where we're trying to go. So we started work about, I'd say, 2 years ago, looking at patient-centered care or person-centered care, because a lot of these people are not patients. They're just individuals who have all sorts of challenges. And we wanted to come up with a model that would be truly person-centric and also would be complementary. We don't want to throw out what's there today. A lot of it works, as I said, very, very well. But coming up with a person-centered model is really, really hard. So we tried to define some basic principles that would allow the model to be developed. And the three principles were holistic. So we wanted something that would actually be based on the whole person. And we've taken on board the biopsychosocial, or BPS for short, model as a way of looking at an individual. And I think it was Nick again mentioned yesterday that nobody asked the questions, how are you doing, or are you okay? And my eldest daughter is a doctor down in Australia, and they had a lady in who had kind of been hit by a car. So she wasn't terribly damaged, but she was a bit losing consciousness and things like that. And she was trying to say something, but they kept giving her injections to calm her down and sedate her and put her to bed. And they got her sorted out in 3 or 4 days while her daughter had died at home. Okay, so she was a carer for a daughter who had Down syndrome and multiple other challenges. So nobody asked the question, you know, is anybody else waiting for you back at the house? I think Nick's question was really good. I mean, we do need to think about people and not think about the event that's just happened. It's not just about an episode. We have systems for dealing with that. We need new systems. The second model or principle we wanted to focus on was the being adaptive. Being adaptive means really meeting the person where they are. We always start out at being where we are, and we know better. If we take somebody with dementia, for example, we're going to know better, and we probably do, and we're in a different reality, but it's not their reality, and we need to think about where their reality is rather than where our reality is. It also has all sorts of other challenges. For being adaptive means we need to be able to change in real time. So the plans that we come up with, and I'll talk a little bit later about care plans and treatment plans, but those plans need to be able to change on a dime, not be something that goes through an entire process. We need to respond in the same way a human being would respond to somebody in trouble, not wait till the process says we have to go through step 42 before we do step 43. And the other impact I think that being adaptive has, it has a huge impact on how we design systems and how we think about systems. If it's going to be adaptive, we can't have a rigid system. The system itself has to change. The way we access data has to change. We have to accommodate new data sources without having to recompile programs and recompile systems. And that's hugely challenging because we're not used to doing that. The third piece I think is really, really important. Well, they're all important, but is multidisciplinary. The model of care is fundamentally got to be multidisciplinary. And if you roll back the clock 1,000 years, families took care of their elderly. And now we have things like guilt insurance that I've seen over in the US. We're doing a project in China where there are simply no carers. They created an environment there where there was a single child policy. So that was fine at the time. Now that a lot of people are old, there's no children to look after them. So they're actually building entire cities for old people in greenfield sites. So that's not particularly kind of warming, I'd have to say. But like the milking the cow, I think we can't have software that actually gives care. But we can provide software that really helps the team to do a better job. You know, there's two aspects. I think we can help them to do a better job, and like every other role in life or experience in life, carer teams, like our doctors, that we don't want to think about, there is a bell curve. There are people who are at the far right of that curve who are absolutely fantastic, and there are people who are at the far left who are not so good. And I think one of the things we can do with the technology is to try and help shift the bell curve to the right a little. So if we can help the team to be better as a team and to provide care, help them to provide better care, that's something that we can probably strive for and probably achieve. So when we talk about holistic, there's three pieces to that. that we've come up with. One is looking at that BPS, or biopsychosocial reference model. And really it's about looking at and understanding the intersection of those three dimensions of a person. So how do we look at a human being? So we have biological things, issues, and features and feelings and so on. There's lots of social and psychological ones. So if you take, for example, a homeless person, you'll often find that all three of these are issues for them, otherwise they wouldn't necessarily be homeless. If you find someone with dementia or someone, an at-risk teen mum, again, you can easily see how all three pieces come to play. And the real challenge here is trying to identify what is that intersection, like what does it mean? Because it's not just a bunch of data. It's more than that. It's like, what is that data? How do we interpret it? How do we do something useful with it? And for us, it's been a driver for a set of analytics to try and understand that connection and the correlation between those three dimensions. And that's something that we've been working on. Right now we have teams from 5 of the IBM labs working on this. So fortunately for me, IBM took it seriously and decided to invest in it. So we have a team in Haifa, a team in Beijing, I don't do my THs very well, but 3 teams in Dublin, and one in Yorktown up in upstate New York. So that's one area that we're really, really focused on. The second one is what we call social context, which is trying to understand what is the network, what is the support network, what is the environment that you live in as an individual. And those of you who have come from a child welfare world will probably recognize part of this as being somewhat similar to a genogram, which is a kind of a tool used by social workers. But we wanted to try and expand that and bring it out a bit more, because it's not just the relationships, it's about people who influence you, it's about your environment. And the challenge here is to look at the data, the events and the interactions within which a person and a family actually exists. Okay, so that's what we're trying to develop. And the connections and the relationships between those entities give some kind of meaning and relevance to what we're trying to do, or to an understanding of that picture. The other challenge here on this one is trying to figure out, okay, well, how do we come up with a view or a visualizations that different people in the team can actually understand, given that somebody may be a doctor, somebody may be a social worker, somebody may be an administrator. We still need a common language for all those people to be able to have a same understanding from a picture over time. And we need to be able to compare that picture, for example, on the top right, with a similar picture that we had 2 weeks ago, 2 months ago, 6 months ago, and to be able to understand what's changed in a common way. There are all sorts of other challenges about, we don't necessarily want to represent the social context like that on an iPhone. The real estate is not appropriate for that. And it turns out that a lot of the use cases for teams working there's 2 very distinct sets of use cases, which I'll talk a little bit about later on, which means that we don't necessarily have to produce images like this onto a 2-inch by 3-inch piece of real estate. And the whole point of looking at that model, the biopsychosocial model and the social context, is to try and understand the vulnerability. Like, how do we measure human vulnerability is kind of where the ultimate goal is of the research. We know we need to measure it across those domains of health, food, safety, shelter, education and income, because we know that they are the major factors in affecting well-being or health, and as I think Nick called it yesterday, wellness. But we need to be able to understand, how do we score those, how do we weight them, how do we evaluate them, and then how do we use that to drive a set of services and a team that can actually help support that individual or family. So it's a major kind of challenge for us, and we also need to be able to understand different data sets and different types of data, because it's not just reading databases and pulling data from 4 or 5 systems. We need to look outside beyond that to the open data world, but also we need to be able to find new data without having to program it. So we need to be able to understand and reach out and find new entities. In Curram today, we do have a version of this, just in one little piece of it, where we allow people to kind of search for services, whether they're government services or community services, and bring them together in a way that represents where they physically are. And I'll come back to that later, but it is important to try and bring those services together around the individual, and not just give you a list of services and then you go to another screen to find another list of different services. And that's a huge challenge because systems are just not built like that today. They're built around episodes and they're built around transactions. In terms of being adaptive, there are kind of 2 or 3 kind of key points here, I guess. The first one is we usually ask the question, where are we now, when we need to ask the question, where are they now, as I mentioned earlier. And we often start, even when we look at designing business processes around care, we start with, okay, well, what are the stakeholders got to do? What are the use case for the care worker? What's the use case for the nurse? What's the use case for somebody else? And really we got to start with, dump all those and start with, well, what's the person doing? Okay, what's their day look like? And when you talk to vulnerable populations over time, you find out one thing they have in common is they all just want to get through the day first and foremost. That's number one. Whether that's a JJ kid in trouble, whether it's an elderly person with all sorts of challenges, or whether it's a homeless person, if you really sit down and talk to them, they want to get through today. That's number one. So I think that's the baseline use case. So I think it's very different starting from there and say working your way up, what does the person want to get beyond that, rather than saying what's the use case for an individual, for a particular worker. So when we look at that, on the top right, which is probably not legible, which it probably doesn't make any difference, it's a treatment plan that I dug up off Google or wherever, somewhere I did a search for treatment plans, and it has a list of things for an individual. And it has like breakfast at 7, injections at 7:30, medication at 7:45, some lunch, followed by more injections and medication and chemotherapy. And then the same thing happens, and for some reason they stop feeding this person at about 3 in the afternoon. They don't seem to get fed after that. And it goes on like that for every day, and that's a treatment plan. And you know, I think it's important that we don't confuse something like that with caring. They're not the same things. That's a treatment plan. That's a task list of things to do to a person. It's not a caring plan. It's not a care plan. And I think we need to put the person front and center, which means turning our systems upside down. Because nobody that we've come across thinks like that. And you've got to put yourself into that position. If we take a very simple example, if you look at the last piece of that slide, if the way we work today, it's kind of more like you get a set of directions to go somewhere. Here's the plan, okay? And then that's fine if everything works out absolutely perfectly. And with vulnerable people, that's never going to happen. And for most of us, it doesn't happen. We start off with doing something in the morning, and we end up with something else. So it's not really useful because nobody knows what to do when something goes wrong. Whereas if you have a GPS instead of directions, if you have a sat-nav, when things go wrong, it just simply recalculates and moves on and gives you another approach. And that's the way we need to think about adaptive systems. So when things change, the system needs to correct itself. The system needs to help the team to figure out what to do. We shouldn't just throw up an alert and say, hey, something has happened and you need to fix it. That's not particularly good. We don't appreciate it when we're driving, and when we're trying to provide care, we certainly don't appreciate that kind of a style. But that's what we have today, and we raise alerts. And if you ask people to come up with use cases for caring, I guarantee you they'll start off by saying, okay, so what's the care worker going to do? What does the care coordinator need to do? That's absolutely the way the conversation goes. And that's the part we have to actually fundamentally change. We do need to understand the physical environment as well, which is something we typically don't take into account at all in enterprise systems, whether in the HHS world or anything else. So for example, in the scenario here, if one of those things on the list had been an appointment to go to the hospital, so what would have happened to the meal that was coming at 12 o'clock? Somebody was going to arrive with Meals on Wheels at 12 o'clock, and we're down in the hospital. We're supposed to be out by 11. But we're still sitting in the waiting room at 12:15. So are we just going to let the meal come by? We're going to take the cost of the meal. It's just going to sit outside the door somewhere. And then is the person providing care, the person who's brought the lady to the hospital, are they going to get a meal for her on the way home? Are they going to know to do that? Should we tell them that? You know, should we know how far we are away from the hospital if we finish the appointment, so that we know we can make it back in time to get the meal, so that we don't have to cancel it? So even very simple things like that require a huge amount of thought when you're trying to get a system to think like a person. And it's the age-old challenge of AI. I don't mean artificial insemination, back to the cows again. A lot of Irish people the farmers made a lot of money from the European Union out of AI. But the AI that we kind of had years ago, where you got questions like, tell me about your mother, and then the whole thing went off into hyperspace and nothing happened. And we had years of expert systems and languages that were supposed to give us AI and all the rest of it, and nothing ever really materialized. But systems now need to be a bit different. We have better technologies. We have ways of actually learning systems and systems that learn. So I'm just going to give you one example of this. Not that you'll be able to read it, I suspect. Jesus, no, it's almost impossible. Okay, so what this was, one of our early kind of prototypes to look at what an adaptive system might look like and how it might work. So what you're looking at here in the top right, sorry, up here, is the data from the HHS from Curran. So just basic human services information around TANF, SNAP, Medicaid, etc., child welfare, child care. So information about an individual. The individual in this particular thing is Bob Pugh. I don't know why they picked that name, but anyway. So we're looking at that information and we're trying to maybe make an assessment of something. So we used DBpedia, which is like the digital version of Wikipedia that provides definitions, gives ontologies for what things mean in different circumstances, like what's an address, what's a hospital, those kind of things. And we used that information to get a vocabulary to go and search on the web and used kind of semantic data, semantic link data to go find other ontologies, to find other information. So we eventually found a clinical vocabulary that we could use. So when we found a reference to, for example, a disease in something in the Curran system, we were able to go to that clinical vocabulary, find it, and find out some more information about that disease, and then find out information about the locality, find out information about the healthcare system, find out other issues that are going on in that physical environment. Because at the end of the day, vulnerable people are no different to the rest of us. They all live somewhere, and where you are is where a lot of things happen, whether they're good or bad. That's where it's at. So we do need to understand the environment. We do need to look at it. So what we've been working on here, you can see on the left, is a whole set of vocabularies around social care, around healthcare, around local data, and the open data plays a huge part in this. So the work that Dr. Shah had been doing has been really, really powerful in making these kind of things possible. I'm getting all sorts of warning signs here, so I'm going to keep going. The last piece of this is multidisciplinary, and this is one of the core pieces, obviously, of the whole equation. And there are two very distinct sets of processes or use cases when it comes to supporting a team to do their work. The first one is around the initial assessment, the planning and the provisioning of services, and then the subsequent reviews. And the second set of use cases is around the delivery, the service delivery and managing that delivery. And they're very distinct and very, very different in their requirements. In the first case, when we want to do the assessment and planning, we need to understand that social context. We need to understand the vulnerability. And we need to, very importantly, understand the safety net. So when we come up with a plan or a set of services, we need to know how we're going to deploy those services. So where's the best place? Where's the best care team? Where's the best connections? What's the most connected environment to support the client and the family that we're trying to work with? And then ultimately at the left, we need to actually have a plan that implements that, at least gives us the top level plan, the starting point. And in the real world, we need to look at that plan and we need to look at multiple options or variations of that plan based on cost, based on likely outcome, based on the accessibility of the services, and based on a priority issue. Like often when you meet somebody where they're at, they will tell you that the only thing they care about, for example, is one particular issue. Maybe it's smoking, maybe it's alcoholism or something. And if that's what they want to do first, it doesn't matter whether you think they should do something else. If you want to build credibility and trust with that person, you better start with what they think is the biggest issue. So you want to drive a plan. We wanted to be able to drive a plan based on that kind of model. So if you can imagine the environment where we have in the trading rooms in Wall Street and also all the banks, they have multiple monitors for these kinds of situations. So we're looking at technologies that will allow a team to collaborate in a way that allows them to see all these things simultaneously, so they can actually make decisions and share and do case reviews in a way that actually you would expect to see in the 21st century. In fact, some people would say we might have expected to see this in the 20th century. But during that initial assessment, planning and provisioning phase, the team needs to be able to look at the different components and be able to play with them and try and come up with different scenarios. You need to do what if scenarios. What if we drove this plan based on cost? What if we drove it based on outcome? And the outcome one is kind of interesting, because if you look at some of the vulnerable populations, if you look at, for example, somebody with dementia, what's the outcome? What's your new outcome going to be? We all know where that one is going to end, and you're not going to change it. So the outcome is not some magic formula that's going to give us a number at the end of the day. You can achieve an outcome, but it won't be maybe what you started out to do, and maybe we should reset the goals as to what the outcome we're going to achieve could be. The other side of this is delivering the services and managing them. So unlike the planning phase, where you're looking at a very different collaborative environment, where people do case reviews and they do kind of case conferences like you would see in hospitals or you will see in social care, etc. This world is quite different. The team is not actually sitting together. In fact, they're anything but. They're in different places, doing different things at different times. And it's a very different design point when you think about collaboration in this environment. It's nothing got to do with the first model. So it's a totally different type of collaboration, where we want people to respond to events in real time, and we want to communicate with the team in a way that allows things to happen in real time. So if a vulnerable person, for example, has a fall, we need to be able to readjust the schedule now. It's no point saying we'll do it tomorrow when the thing gets executed. We have to do it right now. I'll give you one example of how we tried to work to support the teams. So this was a model that we built. We took it from an example from a visit we had in one of the East Coast states, where there was a lady who had been just discharged from the hospital that came into the community care team. And she'd been, it was a DV case, so she'd been beaten up by her husband. She needed more treatment, but she had a child who was pretty much terminally ill, and she had a couple of kids who needed to go to school. So the challenge for the team was, the lady arrived in, she needs a place to stay. She doesn't want to be near the husband for obvious reasons, but she needs to be near the hospital for herself. She needs to be near the hospice for the child, and she needs her other two kids to go to two different schools. So where do you put the house? Where do you get the apartment was the problem. So we had the data, this is a map of Dublin, so we didn't have the data for where the incident happened, but we had the data for Dublin through the open data information that they provide. And we were able to kind of get the research teams to figure out an algorithm to look at the different options for public housing. So on the left-hand side, you get all the options. There was about 700 or 800 houses or apartments that would be suitable for the basic requirement of a woman and 3 children. The real challenge was she didn't have a car, so we needed to figure out how do we find the ideal house or the optimal house or apartment that would allow her to do all the things that she needed to do. So the team would obviously be struggling with this forever and eventually just pick what they think is a reasonable location. What the software was able to do was to look at all the bus routes. So it went through 4,000 different bus routes for the 500 or 600 or 700 locations. I looked at all the different stops on those bus routes and did all the calculations to figure out where would you put this person in a way that they could most easily get to those 3 locations and be not too accessible from where the ex-husband was. So something that might have taken forever, as in people would just give up and pick another house, or pick a house, took about 3 seconds. So that's where we need, I think it's a good example of where the software can't solve the problem, but it can certainly make it much easier for the team to provide the right level of care for that individual. So I think it was hugely helpful, even though it didn't actually totally address the problem. It actually helped the team do their work. The other part that we mentioned earlier on is the cost dimension. And part of the team, somebody on that team, whether it's the care coordinator or the manager, somebody is thinking about cost. And the system, a patient-centered system, needs to look at cost and be able to predict when the costs are going to change. Like at some point it won't be cost effective and it won't be efficacious to have the person at home. We obviously want to keep them at home as long as possible, because universally that's what people want to do. Even if they're dying, they want to be at home. And I remember being in the hospital when my mum was in hospital a couple of years ago before she passed away, and there was another old lady in there, and every day I went in, she'd come over and ask me the way to Stony Batter, which is an area in Dublin where she was from. And I'd always say to her, why don't you sit down now, I'll get the nurse and we'll sort it out. And she'd forget about it, and then the next day it'd be the same. And eventually she came over one day with her key, and she had her shoes on, she was still in her dressing gown and whatever. But she said, Ronan, do you know what? And I said, what? She said, we had a meeting. I said, oh, good, who had a meeting? She said, all of us in the ward. I said, that's very good. And she said, we decided we're going home. And I kind of said, it was so funny and it was so sad and it was everything. But it said it all. I mean, like the only thing people wanted to do was to go home. That was the only thing they wanted to do. And it also happens to be the cheapest place for them to be as well. So it's actually very good for everybody. I'm kind of running out of time, so I'm going to try and answer the question, fact or fiction, which is what was the purpose of the session in the first place. When Nick talked yesterday about what's going on with KIP and what's happening in different places, and he raised a couple of questions at the end. One in particular, he talked about the savings that they achieved in the ER or for the hospital, but the hospital wasn't willing to give it back to somebody else who had done the saving. And that's not a San Diego problem. That's a global problem. And the issue that we're looking at has been around for forever. It ain't new, but we haven't made huge changes. So on the left-hand side, I won't read it, but that was from talking about the dangers in child welfare and child deaths through to lack of integration and human-centeredness. But that was written in the Australian Social Journal in 1969. So it's heading on for 50 years ago. And on the right-hand side is a list of all the things, the times in the UK that they've tried to put health and social together in various acts and reports and whatever. And in 2014, nothing has happened. So 60 years of trying to address, or saying they were going to address that problem, and nothing has happened. So the real question, I guess, for me, I guess, is why is that the situation? And I think the good news is there are organizations who are making strides. Obviously, Nick yesterday with San Diego. I think you saw last year in Camden they were looking at the hotspotting. The hotspotting is really good, but it's when the service delivery meets the road is pretty good. It's pretty important. Hennepin County in Minnesota are kind of pioneers in this space. We're working in New York State with the Health Homes program, which is a classic example of a program for vulnerable populations. And the last one on the right-hand side is in Queensland, when the program is called Growing Stronger, and even the program name gives you a sense of that it's person-centered rather than some kind of program-style name. So nobody disagrees that we should have a person-centered model. I've never given a presentation where somebody said that's stupid or we don't want to do that. But there are a couple of things that happen shortly after everybody agrees. The first one is somebody says, who's going to pay? And the second one is, who's going to benefit? Yeah, that's the reaction every single time. I had a meeting with a city manager, I won't say which country recently, but in a big city, and we explained that if we could cut the time for the ER staff for the ER kind of costs for the homeless population, and he just said, well, that's not my problem, because his budget was to do with the housing and so on, so he didn't care about whether the ER had a big problem or not. And that was the point Nick was kind of looking at yesterday. So if somebody can save it, it's a problem. So why does that happen? The funding models determine who pays, and the funding models are just not streamed in a way that's person-centered, so it just doesn't work. The governance models don't work. I think we probably can't fix the funding one terribly easily, but we can certainly fix the governance one. So in Nick's example yesterday, if people said, okay, if we do A, B, and C, we're going to save $20 million, but Ronan, you're going to cost you an extra $2 million, but John is going to save 18. Then we come up with a model that says whenever we pool, we share, and we share the savings. Or we give a transition period to allow people to migrate from where they are now so that we don't crucify them as part of that transitioning process. That can be affected. I think a very big one is the culture that some of the speakers talked about yesterday, which was the organization goals and the personal goals. If your personal bonus and your salary and your review depends on doing things that the organization wants rather than what you know is required, that's a big challenge for us as people. It takes a brave person to stand up and say, I'm not going to do that, I'm going to do something else. That's not the normal kind of run-of-the-mill. The consent models can be huge barriers. You know, we've had discussions in places like Australia and New Zealand where they go to the extreme on this, and even to the point if somebody signs a consent form, I got asked one time, how do you know they meant it? And I was lost for words. I just said, look, if you don't want to do it, that's fine. I mean, I can go back to Australia, or I can even go home to Dublin. I didn't want to travel for 37 hours to get that kind of a response. I could have just stabbed myself on the way down. So it would have been easier. So we do need to look at communities, and we need to think about building those safety nets and understand those safety nets. And we do need to do prehabilitation. So rather than just doing the rehab when things have gone wrong and somebody's already messed up and they're in a vulnerable situation, it would behove us to do a lot more work and analytics around prehabilitation. So identifying the people who are likely to become homeless, which is part of the research program that we're doing in IBM. And one of the big challenges at the end of the day, you can't actually buy kindness. You can't actually buy caring. You can't force people to do that. They have to want to do that. And because of the bell curve, not everybody is going to do that, but that's why it's important that we help the teams to be better, even if they're motivated by ticking boxes. If the system can be more intelligent and more helpful, then even if they tick the boxes, we can actually produce a better result. And I think that would be really important. I used to tell people in some of the talks to try and do the right thing, and then over the years I got to realize that the right thing was very much open to interpretation. Right for who? And I gave a talk recently to a bunch of kids who were doing coding. So Coder Dojo is an initiative that started in Ireland. It's in about 100 countries now, and it's free. You teach people how to write code. And I told them to do, at the end, instead of that, to do something that they're proud of, rather than to do something that's right. And I think if we actually think about that, it might be something that would help us make some of the right decisions as we go forward. And if the policymakers would do things that they are proud of, as opposed to things that are put a tick in the box, that would probably be very helpful as well. When I looked at the theme, I guess the art of the what's possible, and Daniel brought it up during his talk, what's possible versus the state of the art. And I think some of the speakers we've had so far have shown us that you don't have to accept that those two things are different. You can actually make things that you want possible if you're prepared to push it. So people like Nick, people like Dr. Shah, and some of the other people who presented they're different. You know, they are prepared to push the boat out. They're willing to take a chance. They're willing to not hear no for an answer, and no, we're going to do it. Unfortunately, those people are very few and far between. But that's life. It's the same reason you only had one Pele playing for Brazil. There's only one Ronaldo playing for, well, he used to play for Manchester United, but now playing for Portugal, I guess, and Real Madrid. So the people who really make a difference are different, but they do make a difference, and they can bring those two things together. So we can actually achieve what's possible, or what we want, as opposed to just what's possible. And last but not least, have a think about that question. I'm going to leave you with one slide, just to be careful with big data. It's a big topic. This is a map of a picture of Dublin City from Google Earth. So that's the River Liffey that separates the north side and the south side of the city. And all the green dots, because of that open data that we got from the city, we plotted all the buses. And one of the problems when you look at that picture is a lot of the buses are actually in the river. So sometimes the veracity of the data may need to be kind of checked. So what of course happened, some of them are actually on our only skyscraper there on the bottom right as well. We only have one skyscraper, which is 15 stories high, so maybe it's not a skyscraper. You know, we looked at this, and so sometimes people take data and just take it as being accurate, okay, and you start using it and you make decisions, and you make incredibly stupid decisions. Like, how do we get amphibious buses would have been an interesting question here. Obviously the Irish didn't invent amphibious buses. We do have boats like everybody else. But what happened was that you wondered then, the obvious question was, how does this work on a day-to-day basis? If this is the data, what's the driver seeing? Is he kind of expecting to be drowned any minute now and telling passengers to put on life belts and kind of say, you know, whatever, blow whistles and invite sharks to come and attack you or whatever? Or is he actually seeing that he's actually on the road, which would be a lot more comforting for him and the passengers? And what happened, of course, is the system on the buses, the software on the buses has a correcting algorithm built into it. So when the GPS tells it it's in the middle of the river, the software says, hold on, no, that's not quite right. We're about 5 feet from the edge of the river, or maybe 5 yards or 5 meters from the edge of the river, and it just corrects it. But that wasn't in the raw data. So when you do get big data, be careful of big mistakes. Thank you very much.